Hello, everybody. Very excited to welcome you to this edition of American Thoracic Society Assembly on Pulmonary Infections and Tuberculosis PINE webinar. PINE stands for Pulmonary Infection Network of Experts, and our current edition is called New TB Treatment Guidelines, a clinician's guide to the ATS CDC ERS IDSA 225 update. I'm very, very excited to welcome our expert guests. We have two of the guideline authors here, Dr. Jussi Saukkone, who is the Associate Professor of Medicine at Boston University, and Dr. Charles Daley, who is the Chief of the Division of Mycobacterial and Respiratory Infections at the National Jewish Hospital in Colorado. We also have Dr. Lahari Tumuluri, who is our Pulmonary Critical Care Fellow from Tulane. And my name is Eva Otoupalova. I'm an assistant professor at Tulane University. Just to remind everybody, the aim of PINE is to provide a clinician-focused insights and highlight key updates from pulmonary infections and tuberculosis in an interactive, live, case-based format. What we're going to do is we're going to have Dr. Tumuluri present two cases, and we're going to have Dr. Jussi Saukkone and Dr. Daley comment on various aspects of these cases. We're also going to have questions for the audience during the presentation that you can answer on your computers. And at the end of the presentation, we're going to have about 10 to 15 minutes for questions from all of you. We want to leave a good amount of time for everybody to ask questions to our wonderful experts. So please, if you have questions, go ahead and type them in the chat, and we will get to them at the end of this presentation. So I'm going to say welcome everybody again. Thank you so much for joining. And Lahari, you can take it away.
All righty. Thank you so much. So we have no disclosures, and really the topic today is going to be focused on drug-susceptible TB and drug-resistant TB. We will not be covering any pediatric TB treatment today. So if we start with a case, we have a 50-year-old gentleman. He's coming from West Africa for suspicion for active TB. He has a history of night sweats, about 25 pounds of weight loss, and a cough. He said 3 years ago he went home, and at that time he worked on a ship for 2 weeks, and around him was someone who was coughing and just appeared very ill. On exam, his vitals are normal, his physical exam is normal, his labs are significant for a positive quantiferon, and 3 out of 3 AFBs, which was drug susceptible. LFTs and creatinine are normal, and then we can see his chest x-ray here, which shows a left-sided infiltrate and a right-sided cavitary lesion. The next slide shows a CT of his chest, which again confirms that left-sided infiltrate and a large right-sided cavitary lesion.
So we have a question for our audience right now. What therapy do you want to start? And I'm going to give a little bit of time for everybody to read through the answers. And in the meantime, I'm going to ask Dr. Saukkone, when you have a patient like this with what seems to be a drug-susceptible tuberculosis, what are the factors or questions that you sort of look at before you decide which of the treatment options to start?
So I would consider the age. I would consider whether there's extrapulmonary TB. I'll take it at face value that there is not in this case. What are the other factors, like in terms of their labs? The newer regimens that we're sort of discussing, there are some specific eligibility criteria. So if they're have elevated creatinine or elevated liver enzymes. Those are factors that I would, consider. And then also the amount of time that's needed to treat the patient. Is there some time pressure here? Are they institutionalized? Those are some of the factors. And then their ability to tolerate the various regimens that are available. So in this
Perfect.
case, I think he's 50 years old and doesn't seem to have extrapulmonary TB. So
Okay, so let's look at the results. You can see that the majority of our audience has chosen isoniazid, rifampin, pyrazinamide, and ethambutol for 2 months, followed by an INH rifampicin for 4 months. So your RIPE therapy. Um, Dr. Daly, are you surprised by the results of this poll?
No, I think people are doing what they've always done, which is to give a 6-month treatment regimen with the 4 drugs listed.
What would you choose?
I'm sorry?
What would you choose?
Oh, well, I think that would be a completely reasonable choice, but the other would be A, which would be to use the new 4-month regimen that includes rifapentine and moxifloxacin. To pick up on Yuzi's points in terms of how you decide what to use. I mean, one of the issues will be concurrent drugs, that may prolong the QT. What is their QT? Maybe they already have a long QT.
Yeah.
That might drive me away from that short course regimen. And the other thing is we've had over the years difficulty getting rifapentine in a consistent way. And so, you don't want to start someone and then 2 months later have to switch them off. So you want to make sure that you're going to have a consistent supply of rifapentine if you go that route.
Excellent. Those are all great points. So let's see. We also thought that a 4-month regimen would be appropriate, but as you said, the RIPE therapy for 6 months would be perfectly reasonable as well in this case. So Lahari, you can continue.
So where this 4-month regimen comes from is the new updates that we saw in 2025 for drug susceptible and drug resistant TB. So we'll go a little bit into what study was used for this and a little bit of the details in that.
So Dr. Saukkone, before we get to that, can you comment a little bit on sort of the background behind this guideline update and what were the major sort of patient needs, clinical needs, and sort of, new evidence that led to these particular updates?
So this update is a little different than prior guidelines in that it is an update, just providing additional information. It doesn't necessarily override prior guidelines with respect to certain forms of tuberculosis. And so it really builds on new studies that had emerged. It's still we sort of say in this guideline multiple places that if patients are not eligible for the regimens discussed in this update, then they're referred back to the 2016 drug susceptible guideline as well as the 2019 drug resistant guideline. There were new studies that emerged a few years ago for treatment shortening in drug susceptible TB in adults and in children, and then new regimens that had emerged for MDR TB. And really, this was the culmination of multiple clinical trials that kind of had built up to these pivotal trials that allowed treatment shortening. So we did collaborate with the WHO in putting together this guideline update in a process called ad elopement, which is where we recontextualize the original data that WHO had actually received before publication of a lot of these studies. So we did collaborate with them on that.
Perfect. Thank you. That is, and I just have to say it's a tremendous amount of work and some fantastic updates and evolution. So Lahari.
So the guideline development, just like was mentioned, was targeted update for the treatment of TB specifically as an adaptation of the WHO 2022 guidelines. They did use the grade adultment method. And then really the kind of driver behind this was that, in drug-susceptible TB in clinical trials, we see about a 95% cure rate. However, in real-world implementation, that doesn't really translate. A lot of times that's due to drug intolerance or treatment intensity or resource limitations. So the kind of driver behind all of this was the need for a shorter regimen, something that's better tolerated, and maybe a little bit less resource intensive as well.
Can I just add that
Yeah.
in this multi-society process, it takes a really long time. We started this in early 2023.
Mm-hmm.
By the time all the different societies have contributed their people, we've done the work, and then the review process, it actually, it takes a much longer time compared to, say, WHO, which has, is one organization, and they have full-time methodologists working on this. So the guideline development is a very protracted process.
Mm-hmm.
So over here, we just wanted to go a little bit over what is a strong recommendation, what is a conditional recommendation. So a strong recommendation means that individuals, the majority of patients should be receiving this treatment. Conditional recommendation is more of a clinician decision on which patients would be appropriate for one type of regimen over another one.
Mm-hmm.
So the first question in the guidelines that was brought up was, in adolescents and adults with drug-susceptible TB, is a 4-month regimen composed of 2 months of the isoniazid, rifampicin, pyrazinamide, and moxifloxacin, followed by 2 months of the isoniazid, rifampicin, and moxifloxacin, as efficacious and safe as a standard 6-month regimen, which is our RIPE therapy. In the 2016 drug-susceptible TB guidelines, we see that, RIPE therapy is what's listed. And then when we go to our 2025 drug-susceptible TB guidelines, we see the isoniazid, rifampicin, pyrazinamide, and moxifloxacin 4-month regimen listed. And the recommendation is a conditional recommendation with moderate certainty of evidence.
Mm-hmm. Dr. Daley or Dr. Saukkone, do you want to comment here on sort of the conditional recommendation, moderate certainty of evidence, and how should we interpret that as clinicians in light of the older guidelines and the new guideline updates? Does that mean that we can equally choose either of the regimens depending on patient characteristics?
Well, I mean, there were patient eligibility criteria for this study that underpinned this recommendation. That was the TBTC study 31. And the NTCA actually has a eligibility checklist that basically follows the study's eligibility checklist. So if you don't meet the criteria, eligibility criteria, then you would be, for this regimen, then you would be looking at the standard 6-month regimen. And conditional recommendation says that it's not for everybody, basically. I would point out in the study, the average age was about 30, study 31, whereas in the United States, the average person with tuberculosis is usually much older, may not be, they may have comorbidities, et cetera. So, Chuck, you may have other points.
Yeah.
Well, yeah, and I mean, but to that point, if the study is done in a population different to the one that you're using it, you'll usually downgrade the recommendation. There are a number of reasons how you can downgrade a recommendation, but still, it is a recommendation. And we say if it's in the guidelines and we recommend to do it, then clinicians should consider doing it if they meet those criteria.
Absolutely. Thank you.
So how we came about this drug-susceptible TB regimen was from this NEJM trial, 4 months of rifampicin regimen with and without moxifloxacin for tuberculosis. So I'm going to go over a little bit of what was involved in the trial. So this was a international multi-center open label trial. It was a non-inferiority study with 6.6% of non-inferiority margin. It was conducted across 34 sites worldwide. And really we're looking at 3 different arms. One was our control arm, which was the RIPE therapy, and then 2 treatment arms. One was isoniazid, rifampicin, pyrazinamide, and moxifloxacin, and the other treatment arm was without the moxifloxacin. Really what they looked at in terms of outcomes was favorable versus unfavorable. And how they defined this was a favorable outcome was defined as TB-free survival at 12 months, and unfavorable was a positive culture after 17 weeks, or if someone died, withdrew, or was lost to follow-up from the trial. So inclusion criteria, really anyone over the age of 12 with newly diagnosed TB that was susceptible. They needed one sputum that was positive for AFB or a positive NAAT testing for tuberculosis. And then HIV patients were included. They did need to have a CD4 count of greater than 100. And it was mainly to look at drug-drug interactions between rifampicin and efavirenz. Exclusion criteria, extrapulmonary TB was not included. Pregnant women and breastfeeding, anybody under 40 kilograms of weight, anyone who was treated for tuberculosis within the last 6 months for at least 5 days, anyone with prolonged QT, and then anyone on other heart medications for HIV treatment. So when we look at the groups, so we have the control, we have the rifampicin-moxi group, and then we have the rifampicin group. They were pretty well distributed, and then here you can see the favorable and the unfavorable outcomes. The total amount of patients that were enrolled into the study was almost 2,000 individuals. And then in terms of outcomes between the control and the rifampicin-moxifloxacin group, the outcomes were non-inferior. However, the rifampicin group did show that a little bit of inferiority. In the next slide, we can see this broken down a little bit more. So in the top, you will see the control as compared with the rifampicin-moxifloxacin group, which does show non-inferiority. And then in the bottom, you can see the control and the rifampicin, and you can see that the control is actually superior to the rifampicin regimen. The other thing that was looked at was safety outcomes. So safety outcomes were really death or anything that was a grade 3 or higher adverse events. Between all three groups, there was really no significant difference.
Dr. Daley and Dr. Saukkone, could you just comment on sort of what you see as the real strengths and weaknesses of the Study 31 and potentially as it pertains to the guidelines and perhaps the groups that weren't included, and any other thoughts you have on the study? Maybe start with Dr. Daley.
Yeah. Well, I mean, all studies, suffer from limitations, and one is who you enroll. So in this study, they did not enroll children, so we don't have data on that. They did not enroll pregnant women or breastfeeding, and so that's another group we don't have, and that's very common, but also always unfortunate when we're left with, is it safe to give it to that population? And in terms of the strength, I mean, this was a large study, randomized, that had very high study retention. So I think the outcomes are believable. In terms of the safety, which what we're looking at here on this slide, I would also say that, the safety profile was as good or the same as the control. The rifampicin looked a little safer in terms of AEs, but again, it wasn't as active. So I think we have a safety profile similar in frequency to control with this, but and it's non-inferior. So, I mean, I think it's a good trial, but it misses on some of those inclusion issues that I mentioned. And Jussi, I'll throw it back to you.
Yeah, I agree with those comments. As I mentioned, the study participants, the average age was 30. Many of the patients were not in the United States, so they may not have as many comorbidities, so that the patient population is, probably different than what, we might see. And so as Chuck mentioned, that is a reason to downgrade the recommendation. So what happens in practical experience may be very different than carefully selected patients for a study who are then kind of, coached through the whole regimen, and study coordinators who, get them through the whole thing. It's a little different experience than in real clinical standard practice.
Yeah, absolutely. I have to agree. This has been a very, very well designed and convincing study. Lahari?
Alrighty. So our patient unfortunately has a HIV test that comes back positive. His CD4 count is 200. What do you want to do other than starting your heart therapy?
Okay, we're gonna give audience a couple seconds to answer. And I'm gonna start with Dr. Saukkone here. This seems like a challenging situation. What is on your mind when you have patients with HIV and uh, whether on heart therapy or not, and you are choosing which regimen to start, and which one would you pick in this case?
Well, in theory, either one. I mean, the trial showed that patients with HMPZ and efavirenz, were, able to tolerate both. That said, we've sort of started to allude to the real world issues of medication tolerance, and so adding additional medications could be a challenge in this 50-year-old individual. So I might be a little more inclined to be conservative and go with B, but either option would be reasonable, at least in
Mm-hmm.
theory.
Dr. Daly?
No, I agree with Jussi. I mean, the HMPZ, the trial did include people who were HIV infected as long as their CD4 count was above 100. So we have some data on their outcome, and it looked to be very similar. So I think that's an option, and then standard of care would also be an option.
Excellent. That's what we thought as well. Let's see what our audience thought. We have poll results. Okay, that's what our audience thought as well. Great. And Lahari?
So in this actual study, they only had about 9% of patients that were HIV positive. And of those, like it was already mentioned, everybody had a CD4 count greater than 100. In the left, you see the characteristics table from the study, and on the right, you see the subgroup analyses between that was in the supplement. So here you can see that when compared with the control and the rifampicin moxifloxacin group, there was no significant difference.
Okay. Dr. Daly, do you think it limits generalizability, the fact that there were only 9% of HIV patients enrolled? And do you think there's more need to study this question in this population?
Well, I mean, it is a relatively small proportion, and therefore I wouldn't say it's definitive. It certainly wasn't powered, to look at the difference in HIV. So that will always give us some pause or some proceed with some caution in this group. I don't know. For example, if this was a particularly ill person, low BMI, maybe I would go down that path and probably go to standard of care.
Great.
So additional to that, our patient, we have a student on our service, and they ask us, does the size of the cavity affect what treatment regimen that you use? When we look at our CT scan, our patient has a 6 centimeter cavity.
Okay. And again, give a couple of seconds. And I'm gonna ask Dr. Saukkone about this. What about cavitary TB and the size of cavity? Does that affect our treatment selection? Does that affect your treatment selection?
So in study 31, they did stratify the patients for cavitation, and they looked at even greater than 4 centimeter cavitation. But that was sort of, if you added up all the cavities on a plain chest X-ray, they didn't actually use CT scan in the study. And I think that was to really sort of make sure that there was uniformity across the study sites, and it was really apparent cavitation. So, but there was no difference in the HM PMZ arm compared to standard. So even in individuals who had cavitation more than 4 centimeters, the people with who got HPME, just the rifapentine as the new intervention, they actually did not do as well. So it seems like the moxifloxacin really helped with this issue of cavitation. So yeah, you could continue current treatment.
Great. Dr. Daley, any other thoughts?
Well, there's nothing magic about 4 centimeters, and there may be cavities that I would be uncomfortable using this with. Sometimes you see an entire lobe as a cavity, and I'm not sure I would use a 4-month regimen without data because we don't really have those patients to look at. So, it looks like based on how they did the analysis that in the rifapentine moxi arm, outcomes were pretty similar.
Great. So I have a tricky question. What if this patient had persistent cavity at 2 months with persistently positive sputum? Would you consider switching at that point or extending the moxifloxacin regimen, perhaps? Maybe let Dr. Saukkone answer first.
Yeah, I might, and I agree with Chuck's point. If there's very extensive cavitation, I might not be looking for a reason to shorten treatment. So, yeah.
Great. Dr. Daley?
Well, one of the things that we didn't address was what was addressed in prior guidelines was this idea of how cavitation might affect duration of treatment. In the prior guidelines, if you had a cavity and you did not convert your cultures by 2 months, we recommended extending the total duration of therapy. With this specific one, I don't believe we addressed that, and I can't even remember if we discussed it, Jussi, about doing something similar. Do you recall?
I think in the implementation section, certainly with the drug resistant, we did talk about treatment extension. And so I don't know if we specifically recommended extension for this particular regimen. Yeah, so I'm not sure, but I think that's still an option to extend the treatment.
Great.
Yeah, I think, again, this gets into the art of medicine. I think in a practical situation, in a Department of Health, and this person's not converting their cultures during an expected time frame, that I would feel very comfortable extending the duration.
Yeah, it does sort of throw the reader of the guidelines back to the original 2016 recs.
Great. Thanks for clarifying that.
So in the study for tuberculosis, like cavitary TB specifically, they had about 40% of individuals that did have a cavity greater than 4 centimeters, and there really wasn't a difference between any of the groups in terms of outcomes, and there was nothing significant between them. So, we have this patient, he's 50 years old, he's got active tuberculosis, he's now diagnosed with HIV CD4 count greater than 200, and he has a 6 centimeter cavitary lesion. How do you want to monitor him?
So I'm going to ask Dr. Daley here, as opposed to the RIPE therapy, what are the specific side effects and the specific things that we need to watch out for in the moxifloxacin 4-month regimen?
Yeah. The main thing would be QT prolongation, and that's something that is listed in some of your choices here, EKG, and not in others, which I'm sure you'll talk about. The one thing that you don't have to worry about is optic neuritis, because you've removed ethambutol, so you've switched things. Get rid of the concern for optic neuritis, but now have to worry about whether there's QT prolongation. I think the other things with Moxi, of course, are the tendinopathies, so monitoring for soreness in joints, for example, and GI side effects are pretty common. And to Jussi's point earlier, you may not see those in 30-year-olds, but 50, 60, 70-year-olds, Moxie is not a well-tolerated drug. We use it in the NTM space sometimes, and it's hard to get someone through a course.
Saukkone, do you have anything to add? And also, I have a question. Would you monitor EKGs routinely on your patients on moxifloxacin?
So I don't really have much to add there. I believe in the study they didn't find any major abnormalities. I think in our guidelines we do sort of say that particularly the older they are, more comorbidities, you would have a much lower threshold for more frequent EKG monitoring. So probably in this individual I would.
But I would say that we actually do say you don't need to do it on a routine basis in the guideline.
Yeah.
Right, but based on 30-year-olds.
Let's see how our audience has answered. Okay, routine baseline and monthly EKG. So they do agree with you. We initially thought that we might just get away without routine EKG monitoring, but now talking to you and considering the age of the patient, I might actually just throw in an EKG, at least at baseline, and maybe, a couple months later to make sure I'm not missing a QT prolongation.
Yeah, I think we did recommend at least a baseline.
So, as was kind of mentioned earlier, the clinical correlation to real-world implementation was one of the drivers behind this new regimen. And we are seeing a little bit of newer things coming out in regards of how that real-world implementation is playing out with the 4-month regimen. There was one study, they're both very small, one in San Francisco, one in New York. And it did show that there was about a 50% or more drop rate in terms of completion of therapy. And a lot of that was secondary to grade 2 adverse events, mostly GI related.
So this will be a question for both of you, but with the limitations that this is a very small retrospective observational study, similar to the one from New York, did this surprise you? And why do you think that there is such a difference in what seems to be tolerability, at least from the GI standpoint, in this study and the study 31? I'm going to start with Dr. Daley.
Your meeting ID followed.
What is that? So, this is what happens when you take a well-controlled trial and move it into practice. The outcomes are always worse. And one of these is just an age-related thing. I mean, generally speaking, again, our patients are older. They're not going to tolerate some of these drugs as well as young people. They often have more comorbidities. When you go into a trial, you go for a more homogeneous population. You rule out things that could affect your outcomes. So you tend not to have as many comorbidities as you might see in a clinical practice. So I think those are things that make determine this difference between what was seen in the trial and what was seen in San Francisco and what was seen in New York.
Dr. Saukkone.
Yeah, those are all points I agree with. What was actually surprising to me was in both the Galvez New York study and the Louis San Francisco, is that relatively few patients were actually eligible for the regimen. A lot of that was because they had already been started on TB medications prior to showing up in TB clinic, I guess. And then after that, there were, issues of resistance and then extrapulmonary TB that made them ineligible. So I was just surprised that so few were eligible. Many of them, they also had baseline laboratory abnormalities. So all speaking to how sick some of these patients are. And But yeah, I'm not totally surprised that people did not tolerate the regimen once they were on.
Mhm. And related to this, what do you see as the major barrier to implementing this part of the guidelines and using the 4-month regimen more? And start with Dr. Daley again.
Well, we talked about one, which was just access to the drugs in a consistent basis. You just have to have the drug there. Can't be there and then not there. I think cost, the cost is a more expensive regimen, and that may affect some programs. Um, uh, the large pill burden, is going to be a problem. They're going to complain about that, and that's going to take staff time to deal with that. And so I could see why at the very beginning people lean toward the standard regimen because they're just much more comfortable with that and see these other things as potential barriers to completion of therapy or at least more staff time.
Mm-hmm. Saukkone, you agree with that? Do you have anything to add to that?
Yeah. I mean, who would I select for this if they were eligible? I'd
Mm-hmm.
probably just, select a younger person if they're will.
Mm-hmm.
They might be better able to tolerate it. So.
Yeah, great. Okay.
So one other thing that we took a look into was drug interactions. Rifampicin is very similar in terms of drug interactions as rifampin. Most of the time, it decreases blood levels of warfarin, contraceptives, mostly due to the CYP interactions. Then we have moxifloxacin, which has a lot of interactions with HIV medications, blood thinners, and does require quite a bit of food and drug interaction education on when to take what medications, how to eat with it.
Mm-hmm.
So we
Right,
have another.
moving on.
Alrighty. So we have a 68-year-old lady. She has a history of tuberculosis in her childhood. This was in the Philippines, and she was fully treated for it. Now she's developing a dry cough, mostly at night, some malaise, a little bit of night sweats. She had an EBUS, which shows granulomas. And on your exam, vitals are normal, physical exam is normal, but her lab testing does show positive quantiferon and 3 out of 3 AFP positive. LFTs, creatinine are normal. On the X-ray here, we see that lesion, and then here on the CT, you can see that she's got a small cavitary left upper lobe lesion. When we do drug sensitivity testing, it does come back resistant to rifampicin and also resistant to INH. Everything else is sensitive. So just to go over a little bit of definitions, drug-resistant TB, when we say MDR or multi-drug-resistant TB, we mean that it's resistant to at least isoniazid and rifampin. Pre-XDR, pre-extensively drug-resistant TB, means that you have the MDR component plus an additional resistant to fluoroquinolones. And then XDR TB, or extensively drug-resistant TB, is not only the fluoroquinolone resistant, but also one other additional drug from the WHO priority, so like bedaquiline or linezolid. Here you can see a map with some of the hot spots in the world of where we're seeing a lot more incidents of MDR-TB. So what therapy would you want to start on our patient?
Okay. So we give audience again a little bit of time to read through all of these options. And maybe I'm going to start with Dr. Saukkone here. Could you tell us a little bit about, does your sort of thought process differ a little when you're thinking about a drug-resistant TB in terms of what you look at and how you choose your regimen? Or do you look at the similar things as well, kind of drug interactions, HIV, cavitations, etc.?
Well, I mean, yes, I would consider all of those. I um, I think that there's enough evidence here to say that the 6-month regimen here is going to be good. I mean, overall, I mean, our regimen duration for MDR-TB has been gradually decreasing.
Mm-hmm.
But yeah, I would consider all of those things. I'm not sure that most of those factors would make a huge difference. I
Mhm.
think the limitations of some of the studies that we'll discuss are that
Mhm.
people with HIV and low and CD4 counts less than 100 were, not included, pregnant women
Mhm.
and breastfeeding and so forth, and children. So younger children were not.
Mhm.
Those are some things I would consider. And then also the extent of extrapulmonary TB.
Mhm.
So if they have CNS or bone TB, those would be exclusions in
Great.
addition to those subgroups.
Great. Let's see what our audience thought. Okay. Bedaquiline, bertalanide, linezolid, and moxifloxacin for 6 months. So B-Palm. Uh, Dr. Daley, would you agree with this?
Yeah, I mean, I think the first thing I look at is the isolate quinolone susceptible,
Mm-hmm.
and you have to have a rapid method of assessing that right at the very beginning. So either sequencing or other methods like line probe can give you rapid quinolone results.
Mm-hmm.
And yeah, I think this is a reasonable regimen, all oral, short, pretty well tolerated.
If you don't have a rapid method to assess for fluoroquinolone resistance, let's say, would you consider just B-Pal instead in this patient? Just leave the moxifloxacin out?
Yeah, no, I would start Demoxy pending my phenotypic.
Okay.
Yeah.
Great.
So in the guidelines, there are two additional questions in terms of MDR-TB. So there was in adolescents age 14 or older and adults with rifampin-resistant pulmonary TB, is a 6-month B-PAL regimen as efficacious and safe as the current 15-month or longer drug-resistant TB regimen? And then the other question that was addressed was in adolescents aged greater than 14 or older with adults with rifampin-resistant and fluoroquinolone susceptible to pulmonary tuberculosis, can we do the B-Palm 6-month regimen? And is that as effective and safe as a 15-month regimen?
Mm-hmm. Great. So Dr. Saukkone, and I'll turn it back to you. You already sort of mentioned a little bit, but for those of us that are not as familiar with multi-drug resistant TB because we simply don't see it too much, could you give a very brief overview how that treatment has changed over the past, few years and where we are currently with MDR TB treatment?
Yeah, so I mean, historically, we've had treatment regimens that went as long as 18, 24 months, with efficacy rates about anywhere from 50 to 88% in really well-functioning programs. And a lot of that had to do with not only how sick the patient was, the extent of their disease, but really the functioning of the programs for MDR-TB. The first trial that really was a breakthrough was the NICS trial that showed about a 90% cure rate with the use of linezolid. There was toxicity attributed to the high dose of linezolid at 1,200 milligrams. And then I think we'll probably talk about some of the other trials. But those really sort of Xenix trial established the dose of linezolid at 600 milligrams and the duration, and then the TB Practical trial really looked at a comparison of in a randomized way, whereas WHO also did look at Xenix data versus individual patient data, and still found in both of those trials reason to accept a 6-month regimen. And really, around the world now, the BPAL-based regimens have been used with great success. We can discuss that a little bit later.
Right.
So this is the 2025 MDR-TB treatment guidelines. So it shows rifampin-resistant, fluoroquinolone-resistant, we would do the B-PAL regimen. And then in the rifampin-resistant and fluoroquinolone-susceptible, it would be the B-PALM. This is a strong recommendation with low certainty of evidence.
Yeah, I would just comment on that. It's a strong recommendation, but very low certainty of evidence. And generally, we like it when those line up. And it's a strong recommendation to very high certainty, moderate to high certainty of evidence. But just where the other recommendation was downgraded, this one was upgraded. based on that. And again, there's a process by which you go through in guideline development that allows you to go one direction or another. It's still a strong recommendation from the committee.
Yeah, we actually got a lot of pushback on that from reviewers, and we sort of cited several things. One is that at the time we were considering the data, there wasn't as much real world experience, but members of the guideline team felt strongly that this was a very effective and safe regimen. I should also note in TB Practical, it was stopped early because of treatment efficacy concerns in the standard arm because of treatment discontinuations. So, so all of those factors kind of led into this recommendation.
Right.
So just like what was being brought up, there's kind of three big things that went into the development of the newer updates for drug-resistant TB. One was TB Practical, the other was Xenix, which we'll talk about, and then the data set as well. So here we can see in TB Practical that when compared with BPAL, BPALM, and then your injectables that were the old recommendations, we can see that there is a significant, so it was originally a non-inferiority study. However, when looking at success rate, failure and recurrence, as well as adverse events and death, a TB Practical regimen of BPAL and BPALM both were superior to the injectable therapy.
Yeah. Do you want to comment on the Xenix trial a little bit as well, Lahari? Sorry.
Yes. So the Xenix trial looked at, like was mentioned, linezolid dosing. And so it looked at a 600 milligram dosing in comparison to a 1200 milligram dosing. And it showed that the 600 milligram dosing was equivalent in terms of therapy, but better tolerated in terms of adverse events and side effects. And so that's kind of how that linezolid dosing came about.
Dr. Daley, did it surprise you when the first TB Practical came out that cure rates were so high and the side effects were so much lower than the, so to say, standard of care with the BPAL and BPALM regimen? And does that align with your sort of clinical experience in terms of tolerability, cure rate, and side effects?
Yeah, I mean, the standard approach using a longer WHO recommended regimen has been associated with pretty low cure rates globally. As we know, in the US, our rates tend to be higher than what's been reported by WHO and others, because we have all the drugs available and we can, bring resources to bear to cure our patients, keep them on therapy. Since we had seen BPAL was excellent, over 90%. In the initial NICS trial, then I wasn't surprised by BPAL-M because moxifloxacin is one of the best drugs we have. So when you add that, I didn't think it was going to go down unless it was related to adverse events and dropout. So it looks like it's right where it should be based on other regimens.
When we dig a little further in terms of safety outcomes for TB Practical and compare hepatic disorders, QTc prolongation, peripheral neuropathy between the standard regimen, the BPALM, and the BPAL, we see that both the BPALM and BPAL outperform in terms of lower hepatic disorders, QT prolongation, peripheral neuropathy, and overall just better tolerance.
And in the interest of time, I'm just going to go to our last slide, which is our recommended BPAL and BPALM treatment monitoring, which is also present in the guidelines. And then I'm just going to briefly ask Dr. Saukkone if he can comment on what are the things he really worries about in his patients on BPAL and BPALM. And do patients tolerate this regimen fairly well in his experience, your experience?
Well, so I have very little experience with these MDR-TB patients, but I can tell you that the published experience is actually very good. Haley et al. Published in about 70 patients, and they found that only 4 patients had significant neuropathy that required a dose adjustment, 4 needed transfusions because of baseline anemia, and then linezolid, contributing to anemia. So linezolid is sort of the main thing. There was another publication, Labuda et al., that found very good tolerance of the medication. The international experience is excellent. In Pakistan, there's like 90%, 96% success rate. The LIFT TB consortium, almost 600 patients, cure rates, or treatment success, I should say, 90+%. All the adverse events in that cohort were, they did occur, but they were manageable. There was a publication from Belarus and Uzbekistan, the experience there, 700 patients, and about 10% serious adverse events. So, I mean, there are deaths that are reported in patients with MDR-TB. It's hard to know whether that's failure of that specific regimen or whether they, were just sick enough, so forth. But in general, neuropathy and anemia, are concerns. For if they're on BPALM, they should have intermittent EKG monitoring, like we said. But really, neuropathy and anemia are the major things that seem to have emerged.
Great. So I'm going to move on to some of the questions from the chat. And Dr. Daley, how does the cost of the medication factor into the decision of starting it? And I think that there's a lot of questions regarding that medication availability and shortage might be a factor in starting the 4-month regimen.
Yeah, I mean, the cost will probably be a no-go for some programs who have small budgets and just can't afford any increased costs. For bigger programs, who are selective in who they give this to, because as we saw, not everyone is eligible, then it may not be a problem for those programs. And ultimately, if you have a shorter amount of time on treatment, at the end of the day, it's probably cost effective to use this, particularly when you compare it to a long WHO regimen, whether that's given orally or with injectable. So I don't think cost is the thing that's just going to be the problem for all programs. Anyways, I think again for me, it's been trying to get a consistent supply of rifapentine over the years has been the thing that has been tough. I mean, and that's been trying to use it and for treating latent infection. And there are times we have not been able to access it.
Right. There is a question from Dr. Bailey. Dr. Bailey, do you want to unmute yourself perhaps and ask your questions regarding the 4-month regimen?
Sure. Can you hear me?
Yes, we can hear you.
Yeah, so I have some concern. I'd like to hear some discussion about the 4-month regimen in terms of the outcomes that were reported. And first of all, US was not well represented, so there's question of generalizability there. But more concerning to me is this was a non-inferiority trial, and the rate of unfavorable outcomes was high in both the experimental and the standard of care regimen, 15%, which seems high for standard of care. So I wondered whether there was some discussion about that.
Great. Thank you. Dr. Saukkone, do you want to comment?
Well, I think the inferiority margin was selected to be 6%, but the actual differences were something like 2%. So they were pretty close. So I do agree with your comments about generalizability to the U.S. and that's sort of been a theme in discussing this. So, but I
Yeah,
think the
I wasn't
difference
wasn't
is
questioning
small.
the non-inferiority margins. Clearly, by the design of the trial, the regimens were non-inferior. My question is the poor performance of the standard of care regimen, and whether that really would track to what we experience here in the US in terms of the performance of standard of care. I mean, 15% rates of very bad outcomes in the standard of care is not, I don't think it really matches with what we expect from standard of care here in the US. And that's what I was pointing to.
Jussi, can I comment?
Please
Uh,
go ahead.
Yeah, no, so this is a clinical trial, right? And they have specific outcome measures, and these outcome measures are not often what we use in our clinical practice. If you look at almost every clinical trial in TB, the poor outcomes are usually worse than what we see in our clinics in the United States. This is particularly the case with the MDR-TB, with global 50% treatment success, but in our clinics, it's 90% treatment success. So I do think we have to be careful looking at a clinical trial outcome where they assign a poor outcome if they die, if they're lost to follow up, and if they're still culture positive. So there are multiple things that get you into that category. And to your point, U.S. was not well represented. So these are probably sicker people than we typically see in the U.S. And so I'm not surprised by that outcome, and I'm not worried about it because I know in your clinic, that's not what your outcome is going to be.
Great. Okay. And then there was another question. Perhaps Dr. Saukkone, what about the argument that follow-up 12 months is short for TB? And there might be some rates of relapse that we might not recognize within the 12-month follow-up with the shorter regimen.
Was that for drug susceptible or drug
Yes, I believe I was for drug susceptible.
Well, I think, it really depends. You have to use your clinical discretion as well. So, there are many clinics do follow people beyond just 12 months. So, if you have a particular concern, then I think it can certainly extend follow-up beyond 12 months. So, I don't know, Chuck, did you have, you were on this group?
Yeah, I think we do regimens, we've tended to follow people longer to the point we don't have good relapse data or recurrence data from clinical trials. So once we get it out into practice, I'm personally more comfortable following people longer if resources allow.
Right. Let's see maybe we have time for one more question. There was a question for whether there's a cumulative effect of MOXIE on the QT prolongation, and if not, does it make sense to do serial EKGs? Perhaps Dr. Saukkone again?
Well, for study 31, it was not felt to be that critical, and so the recommendation was not to do the EKG monitoring beyond the initial. But I would say that if there is always the proviso if there are on concomitant medications that can prolong the QT, or if there maybe other issues. Or the baseline EKG is abnormal, and you really need to keep a closer eye on that. So, and then for drug-resistant TB, we would monitor that like it's shown in the chart there.
Yeah, I would say one of the things to note is that people who had a QTc above 450 were excluded from the trial.
Yeah.
And in practice, I just saw one last week, that was 470, not on, and I was about to start medication. So I personally will be doing baseline EKGs in these patients. Again, they're older patients in the US. They usually are on concomitant medications that can do this, can prolong the QT. So I'm going to do that, even though in the guidelines we didn't say do it routinely, but that's what guidelines are. They're just there to guide us. We don't have to follow them to the letter. We can practice medicine as we feel safe.
I think in the drug-resistant TB section, we do say to, do additional frequency if they're on concomitant medications and so forth.
Yeah, we say to do it because they're on bedaquiline.
Yeah.
Right, which also prolongs the cure.
Yeah.
Excellent. So unfortunately, I think we have to be mindful of everybody's time and here. I want to thank so much to both of our discussants, Dr. Daley, Dr. Saukkone. I want to thank our audience for the excellent discussion and questions. I want to thank Lahari as well for a great presentation. I want to say, I think if you want to continue some discussion beyond just our Pine webinar, you can certainly follow us on X or on Blue Sky under ATS PITB, and we can continue some discussions there. And then this Pine webinar will be available online for your review in a week or so. So thank you all, and have a great rest of your day.
Hey, thank you.
Thank you very much.
Thank you.
Great job, Lahari.
Yep.
Thank you.
Joining.
Thank you.